The typical eligibility criteria included in acute myeloid leukemia clinical trials include pathological documentation of disease, bone marrow documentation, age, performance status, and then organ function and comorbidities. So we built a database that included all acute myeloid leukemia patients that were treated at Cleveland Clinic between 2003 and 2019. We extracted a variety of patient characteristics as well as treatment documentation and then clinical outcomes. And so we extracted comorbidities directly from the patient's medical record and then included laboratory data pulled from their electronic medical record and cardiac function tests as well. And then to analyze the relationship between comorbidities and overall survival and complete response, we built multivariable logistic and Cox regression models. When we looked at the complete response rates, we found that only patients that presented with chronic liver conditions had worse complete response rates than those without such conditions prior to the initiation of therapy. All other conditions were not associated with having a worse complete response. Now, when we looked at the overall survival data, we found a similar pattern. So again, patients who had chronic liver conditions had worse overall survival than those without such conditions prior to the initiation of therapy. All other comorbidities were not associated with worse overall survival. Now, when we looked at the liver function data, the results were a little more nuanced. So patients so laboratory data relevant to AST and ALT abnormalities, which measure your liver function, were not associated with overall survival, no matter how escalated those values were. Now, when we looked at the bilirubin data, also measures your liver function, we found that patients who presented with minor bilirubin abnormalities had very similar overall survival to those without such abnormalities. However, as the bilirubin continued to escalate, survival differences began to emerge, and they were statistically significantly different. Now, the renal function data presented a very similar pattern. So again, patients who presented with minor renal dysfunction measured by their creatinine and their creatinine clearance abnormalities had very similar overall survival to those who did not have such abnormalities. However, as the abnormality became more severe, survival differences became more pronounced and were statistically significant. Cardiac function data revealed a similar pattern. So patients who presented with mild QTc abnormalities had very similar overall survival to those without such abnormalities. Now, the left ventricle ejection fraction data was a little bit different. So patients who did present with mild left ventricle ejection fraction data did have significantly worse overall survival than those without such abnormalities. The dose modification data actually demonstrated that patients who had renal dysfunction or cardiac dysfunction did have a higher odds of having a dose modification. However, it's very important to note that patients that had minor renal dysfunction or any sort of QTc abnormality did not have a higher odds of having a dose modification compared to those without such abnormality. So our findings suggest that we should be liberalizing eligibility criteria for acute myeloid leukemia clinical trials. We specifically recommend removing eligibility criteria relevant to comorbidities, with the exception of patients who have chronic liver condition, as those patients should probably still be excluded from clinical trials because our outcomes suggest that those patients have worse overall survival and complete response rates compared to patients that don't have such conditions prior to the initiation of therapy. So for liver function eligibility criteria, we recommend removing exclusion criteria relevant to AST, ALT, and minor bilirubin abnormalities. For renal function eligibility criteria, we recommend removing exclusions relevant to minor creatinine and creatinine clearance abnormalities. And then for cardiac dysfunction, we recommend removing exclusion criteria relevant to minor QTc abnormalities, but we do recommend that specific trials are designed for patients with more severe cardiac dysfunction, as their outcomes were indeed different than those patients that did not have such cardiac dysfunction prior to the initiation of therapy.